Do you hate waiting? Of course you do, especially in those critical times when a patient comes in and you need to get him or her something right now. You have a patient with ongoing anaphylaxis. The EpiPens are not working. Or there's your severe asthmatic. You've thrown everything at her and she is still decompensating. Or the child with shock who is not breathing enough. He needs positive pressure ventilation, but his blood pressure is so soft he may arrest before you've even secured the tube. You need epinephrine, and you need it now. Not when we're finished mixing the drip. Not when the computer boots up, you log in, you click, and you order it. You need it now. Well, you have it in the crash cart. But how do you give it safely and effectively? It's time to roll up our sleeves, get behind that crash cart bar, and make our own mixed drinks. What'll it be?
You make tough calls when caring for acutely ill and injured children. Join us for strategy and support through clinical cases, research, and reviews, and best practice guidance in our ever-changing acute care landscape. This is your Pediatric Emergency Playbook.
Welcome to the Playbook. I'm your host and coach, Tim Horechko. Well, what can I get you? Let's mix up a nice push-dose pressor, epinephrine. Basically, you take 1 milliliter of crash cart epinephrine and mix it with 9 milliliters of normal saline, which dilutes the solution from the crash cart cardiac epi of 1 to 10,000 to your own little dilute mixture of 1 to 100,000 epinephrine, making it much easier to push in small increments and much safer. That's the main message, but to get there and truly feel comfortable with it, really to be able to remember that in the middle of the night with a little patient in extremis with confidence, we should flesh the topic out a bit. First things first, we use epinephrine for cold shock and norepinephrine for warm shock. Cold shock is what we see in 80% of children with shock. Their systemic vascular resistance compensates so much to keep their blood pressure up that it results in cold extremities. Remember, young children have a hard time increasing their cardiac output with starling forces. They can increase their heart rate, and that's how it starts, right? With compensated shock or normotensive shock. Then their peripheral vascular resistance goes up. We should talk a little bit about how epinephrine works on alpha-1, beta-1, and beta-2 agonist receptors. Beta-1 will increase contractility and heart rate. That's what we want to optimize, and that's really the main thrust of epinephrine's use, the beta-1 effects. As a side effect, alpha-1 gives a little peripheral vasoconstriction, but beta-2 is much better at vasodilation, so the aggregate result is a better pump via beta-1 and a vasculature that's a little less clamped down and extremities that are a little better perfused. The beta-2 effects help with bronchodilation and smooth muscle relaxation as well. Warm shock is what we see in a minority of pediatric cases, about 20%. Warm shock is total autonomic paralysis, and you have no compensatory changes to support blood pressure. If you have a hypotensive child with warm extremities, get to work now because he can arrest at any moment. Interestingly, this pattern is the opposite of what we see in adults. Most adults in shock will have vasoplegia and warm shock, which is why norepinephrine is the go-to pressor for adults, and epinephrine is the go-to pressor for children. Epi for cold shock, norepi for warm shock. A father runs into triage with his 11-year-old daughter, and you hear shouting down the hall. All you can make out is, "It's a bring back now! Grab a gurney!" The skinny girl's head and legs flop up and down with every rush stride the father takes towards you, eyes wide and desperate. You get her undressed on the monitor, and all Dad can say was that she was getting her peritoneal dialysis this morning, and she didn't wake up and felt hot. Her name is Carla. Carla doesn't respond when you place the IO in her tibia. She has sonorous respirations and is intermittently apneic with a 30 pulse. You push fluids through her IO, but you know she's not going to be fluid responsive. In fact, she seems a bit fluid overloaded already with doughy skin. Her blood pressure is 55/40. Luckily, the nurses already have the crash cart out, and you make eye contact with the nurse who pushed it into the room. You nod, she nods, and she hands you the vial of cardiac epinephrine. You start calculating in your head. If she arrests, she's 11 years old, probably 35 kilos. She would need 0.01 mg per kg IV of the 1 to 10,000 cardiac epi, so 35 times 0.0. Who are you kidding? You can't do math in your head. There are other people in the room who can help keep your head and your equations clear. Carla is not coding yet. You don't want to push the cardiac epi. It's very concentrated and it could cause a dysrhythmia. She needs less of an espresso shot and more of a cappuccino. Hold the foam. She needs push-dose epinephrine before you intubate her. You grab the vial. It has a blue top. You grab a 10 ml saline flush and carefully waste out 1 ml of saline. You attach a large needle to the saline flush and pull out 1 ml of epinephrine from the cardiac vial. You give it a little whirl, and now you have a diluted epinephrine concentration from the 1 to 10,000 cardiac epi right out of the box to a new version, the one that you just made, of 1 to 100,000. Your new concentration is now 10 micrograms per milliliter. It turns out she needs 1 microgram per kilogram, so that will be a 35 microgram dose. That math you can do in your head. Your new solution is 10 mics per ml, so she needs 3.5 mLs of your homemade solution. You push it. And you hold on to that syringe until you label it. Right? Why am I making this point? If you set down your little barista creation there without a label, it looks just like a flush. No, no, no. Label it. Okay, there were a lot of concentrations and numbers we just used, so let's unpack. You can order your epi just like you order your coffee. From concentrated espresso to weak sauce colored water. IM anaphylaxis or asthma epi is like taking a shot of espresso, 1 to 1,000. Gets the job done. Sometimes you need a doppio, a double, but that's all right. IV cardiac arrest epi is 1 to 10,000. It's more diluted for safety and for ease of sipping. More like your flat white, espresso and a lot of hot milk, or cappuccino, hold the foam. IV push dose epi is 1 to 100,000. So it's much more diluted and it's, of course, much safer. That's your French press or drip coffee mixed with milk. Café au lait, comme tu voulais. Homemade coffee, homemade epi. Then you have the most diluted version of epinephrine, the drips. They come in two concentrations, 4 micrograms per ml and 1 microgram per ml. The 4 microgram per ml concentration can be made right at the bedside if you take 1 full milligram of epinephrine, that's the whole vial of cardiac epinephrine, and you inject it into a 250 ml bag of normal saline. Et voila, this is now 4 micrograms per ml. The math gets even easier if you take that same stick of cardiac epi with 1 milligram total of epinephrine and you push it into 1 liter of NS. This gives you a concentration of 1 microgram per ml. So you can either make your own drip fast and use the 1 microgram per ml from the 1 liter NS bag, or you can use push dose epinephrine until the formally prepared epinephrine drip shows up. Brianna is a 2-year-old girl who was eating with her family at a restaurant when she started to have a rash on her face, then lots of drooling and fussiness. When EMS arrives, she's wheezing. She gets epinephrine IM. On arrival to you, her oxygen saturation is 86% on a non-rebreather mask. She was clinging to her mother on arrival, and now she just lies back in the gurney. You wipe off some orange-colored grease from her little pudgy fingers and give another dose of epinephrine IM. No change. Now what? Her blood pressure is 72/40. Her heart rate is 130. She needs more epinephrine. You call for a drip. Someone is running to go get it, but you know what that means. More time than Brianna has. You open the crash cart, rummaging through. There it is. The box you were looking for. You rip it open. You verify. Epinephrine, 1 to 10,000. Should you give that? No. Just out of the box, that's for cardiac arrest, 0.01 mg per kg. Brianna is alive. She has a pulse, so she needs a more dilute version of the cardiac epi. You grab a 10 ml flush, a 3-way stopcock, and the cardiac epi. You try a different way to prepare it today. You take the cardiac epinephrine vial and waste 9 mLs of epinephrine, leaving 1 precious ml of epinephrine in that beautiful glass vial. You connect the green Luer lock end of the ampule with the stopcock and the 10 ml saline flush to the stopcock as well. You turn the dial and push in 9 mLs of normal saline flush into the now almost empty epinephrine vial. Give that a whirl. Connect the newly diluted 1 to 100,000 push dose epinephrine vial into the patient's IV, and you are ready to push it. So she's 2. She's yellow on the Broslow tape, say 12 kilos. The vial you hold in your hand is 10 micrograms per ml. So you're holding a total of 100 micrograms. Brianna is 12 kilos, and the dose of push-dose epi is 1 mic per kilo, so she needs 12 mics. For that 10 microgram per ml solution, you'll give her a, let's say, generous 1 ml. You wait. 20 seconds. 40 seconds. 1 minute. That's the onset of action of IV epinephrine. Your crossed fingers touch the monitor. Start the BP. The groaning of the cuff. The click. 94/60. Heart rate 140s. Brianna notices you for the first time and lets out a long, drawn-out cry. And you let out the breath you've been holding this whole time. What's the evidence on push-dose epinephrine, you ask? Well, first, this isn't some crazy trend. Push-dose epinephrine has been used for years, sometimes called push-dose epi, low-dose epi, diet epi, epi-light, a whiff, a dash, a kiss, a pinch, a soupçon, just a little drops. By the way, if you're doing a literature search yourself, then try the term low-dose bolus epinephrine. The American Heart Association's Pediatric Advanced Life Support Program recommends the following, quote, for treatment of hypotension or persistent bradycardia with a pulse in the patient with an at-risk myocardium, give low dose via central administration, 1 microgram per kilogram. They also say doses in this scenario should be administered via central venous catheter or intraosseous catheter and titrated to effect based on the patient's response with a reasonable starting dose of 1 microgram per kilogram. This is 1/10 the standard resuscitation dose for pulseless cardiac arrest or symptomatic bradycardia. Okay, so even the American Heart Association is on board. Now, granted, they talk about central access, but at this point, you're doing whatever you need to do. Most of these patients at this point would have an IO, so you're on board with that. We also know that this is such a dilute solution, it's not going to hurt their little veins. Ryder et al. In Pediatric Critical Care Medicine studied low-dose epinephrine boluses for acute hypotension in the PICU. They looked at patients admitted to the PICU over a year period who received low-dose IV bolus epinephrine, and low dose for them was anything under 5 micrograms per kilogram. They found that within a minute of administration, the median heart rate increased from 130 to 150, and the mean arterial blood pressure changed from 51 to 75. They noted variability in mean arterial blood pressure response, and so thought that this is a reasonable approach. Ross et al. In Resuscitation studied pre-arrest bolus dilute epinephrine in the pediatric intensive care unit and found that in the majority of pre-arrest pediatric patients, there was an increase in systolic blood pressure and a lack of blood pressure response was associated with poor outcomes. Some studies looked at human errors and safety errors that were found, and most of them concluded a low rate of inappropriate dosing. In Resuscitation Plus, just this year, Ross et al. Surveyed pediatric resuscitation experts about their use of peri-arrest bolus epinephrine. They got a 78% response rate, which is pretty good for a survey when you're doing that type of methodology, and found that initial dosing strategies ranged from 0.1 micrograms per kilo to 10 micrograms per kilo, with the most commonly reported dose of 1 microgram per kilogram. Sophie is a 7-year-old girl with asthma. She uses her rescue inhaler almost every day and has had trouble getting in to see her pediatrician. She mostly sees you when she isn't feeling well. You remember that Sophie is often sicker than she really seems whenever she shows up in triage. Sophie is one of those poor perceivers of her asthma. She's had so many autonomic surges from her exacerbations that she doesn't present with agitation, diaphoresis, or air hunger anymore. Her exacerbations are quiet trips down the river of hypoxia until she floats into your ED and you turn her around. This evening, Sophie is not talking. She's not making eye contact. She's breathing at 50 per minute. Her SpO2 is 78%. On NEBS, she's only 84%. She has poor tidal volume and a relatively silent chest. You don't hesitate and you give her the pre-filled syringe of 1 to 1,000 epinephrine intramuscularly into her lateral thigh. You get an IV in, you give her methylprednisolone, you give her magnesium, you give her fluids, you throw that kitchen sink at her. She's a little better, but you're worried about stepping away from the bedside. You wouldn't intubate her. It's really the last-ditch effort for asthmatics. We can hurt her if we can't get the vet settings just in tune to what her body is doing right now. In addition, of course, to all the problems with an apneic period or pneumothorax and all those problems with intubating a crashing asthmatic. Sophie is going to need an epinephrine drip, but right now it's just you and the nurse. The place is overwhelmed at the moment. You reach for the crash cart. The box of 1 to 10,000 cardiac epi is staring at you in the face. "Hello, Epi, my old friend," you mutter into the box. The nurse looks at you sideways. "What?" Never mind. You take out the vial. You use the needle to inject into the bag of 1 liter normal saline. You label that bag and you give it a shake. You just injected 1 milligram of epinephrine into 1 liter of normal saline, which gives you a drip concentration of 1 microgram per ml. Sophie is 30 kilograms, so at 1 microgram per ml, she'll need 30 micrograms per minute. Luckily, in this drip concentration, it's even more dilute, and 1 microgram per 1 ml equals 30 mLs per minute. That, of course, is going to be the higher end of what you would normally give. So if you want to give, let's say, the middle range, then just half it. You start her on 1 microgram per kilogram of the 1 microgram per ml solution that you just whipped up. And in 10 minutes, she's sitting up. She's talking to you. Of course, only in 2 to 3 word sentences, but she's better. You turn down the drip and finally find a computer that you can put the EpiDrip order into. The main takeaway here is to think about what's practical, what's safe, and what's required of us. Ideally, we have all of the staff our little hearts could ever desire at arm's length, and orders are just put in by connecting your brain to Wi-Fi. All right, now that you stop laughing, you can see how sometimes it's up to us to make things happen. To review, low-dose bolus epinephrine can be life-saving in adults and in children. In adults, it's mostly used peri-arrest or to give you some blood pressure cushion before a precipitous intubation. In children, we can use it too, very safely. In fact, this is where pediatrics can hold its head high. Calculating milligrams per kilogram is what you do in your sleep. In children, we can use push-dose epi for the anaphylaxis that doesn't improve with IM epinephrine. Remember, intramuscular is always the preferred route. It is inherently safer. But the definition of insanity is doing the same thing over and over and expecting a different response. If you have little to inadequate response with IM epi in anaphylaxis, you should give a push dose of diluted epinephrine. The 3-way stopcock method is probably safest since you're wasting the extra 9 mLs of epinephrine from the vial, leaving 1 ml in that vial and adding 9 mLs of saline into the glass vial. Your resulted dilute 1 to 100,000 epinephrine is already marked epinephrine, and no one will mistake this for a flush. Now, this is, of course, the opposite order of operations to the traditional method of wasting 1 ml of normal saline, giving you 9 mLs of NS in that flush, and pulling in 1 ml of epinephrine. The trick here is only just label it. Thou shalt not let the syringe leave thine hands without the label. Either method gives you 10 micrograms per ml of 1 to 100,000 solution. Children will need 1 microgram per kilogram per minute of this dilute 1 to 100,000 solution. Keep on spritzing until you see an effect, usually within minutes. My advice, go over this a few times in your head until you feel comfortable that you can retrieve it from your brain at 3 a.m. One more time. Repetition is the mother of memory. 9 mLs of NS plus 1 ml of cardiac epinephrine of 1 to 10,000 gives you 10 mLs of push dose epinephrine 1 to 100,000. Your new concentration is 10 micrograms per ml. This dilute solution can be given 1 microgram per kilogram per minute. So a 1-year-old 10 kilo infant needs 1 mic per kilo or 10 micrograms. You just made a 10 microgram per ml solution, so you give 1 ml. A 3-year-old is 15 kilos. He needs, of course, the same thing, 1 mic per kilo or 15 micrograms. You give him 1.5 ml of your awesome home-brewed dilute solution. A 5-year-old is 20 kilos and he needs how many mics per kilo? 1 mic per kilo. So he gets 20 mics of your dilute solution. At 10 micrograms per ml, you're going to give him 2 mLs. And so, in summary of the summary, 9 ml NS plus 1 ml of 1 to 10,000 cardiac epi gives you 10 mLs of diluted 1 to what? 1 to 100,000 epinephrine, or 10 micrograms per ml. How many micrograms per ml in the push dose epi solution you just made? 10 micrograms per ml. What's the dose per kilo? 1 microgram per kilogram per minute. Boom! You just saved a life. All fun aside, medicine is a team sport. Talk about this with your colleagues, have a discussion before the need arises. But when it does, at 3 a.m., what's the recipe? 9 mLs of NS plus 1 ml cardiac epi. What's the concentration? 10 micrograms per ml. What's the dose? 1 microgram per ml. You got this. Until next time, remember, you are the champion for the child in front of you. Take care.
Thank you for listening to The Playbook. We welcome your comments, questions, and feedback. Email Tim at coach@pemplaybook.org or drop by our website for show notes and more strategy at pemplaybook.org. See you there.